Please help spread the message of Frequency Specific Microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about Frequency Specific Microcurrent.
See my butterflies? Look.
Oh, so pretty.
My sister had one and I had t-shirt envy, so I bought one.
I love that.
Peace sign with butterfly.
But I have the butterflies in the background because butterflies are like a big deal for me.
Butterflies are a very good thing.
Yeah.
It's like transformation.
Yes.
Caterpillar.
Yep.
What a transition zone.
Yes.
Butterfly.
And they represent that struggle is necessary for growth and however you want to say it, rebirth, transformation, because as the caterpillar is changing, it's in that very tight cocoon.
Mm-hmm.
And there were these scientists that would pull the cocoon apart before it was ready. And these butterflies died.
Yeah. No. Can't
So
do
it's pushing on full, have this timeline. And as much as we want to expedite healing and we have an idea what frequencies we want to use and what the patient needs, there's this other timeline that we have to just support as best as we can.
And patience, because you can, I guess, but you can't learn without that period of discomfort when that learning curve you describe, you start out being unconsciously comfortable and competent, unconscious competent. Then you learn something new and you go to conscious incompetence. You're not very good at the new stuff and you know it. And you know you're not good, but you're struggling to learn it.
Yeah.
And then you become consciously competent. You're better at it. You're getting good at it, but you still have to think about it. And then once you incorporate the new stuff, then you are back to unconscious competence with the new stuff incorporated. And with FSM, I do that all the time. And I've been doing this for 30 years. So those of you that have been doing this for however many, 5, 10, 2, 1 year, that kind of feeling of, I'm not sure what I'm going to do, but there's this script and if I follow it, I'm going to be okay. And then you find out whether or not you're right. So I had a patient from Georgia or someplace contact me by phone, like kept calling me. And he said, I fractured my sacrum and they put a screw through it to heal it. And I think I was allergic to the screw because my entire lumbar plexus shut down. So he has nerve pain and motor weakness. And he said, and there's one practitioner in my area, and I called that practitioner to get me in, and he said he wants to talk to you before he'll treat me. And I thought to myself, that's only nerve pain. I said, what's the problem? So then I talked to the practitioner yesterday, and he said, okay, so what do I do? And it's 40 and 396. We're assuming that the imaging is correct, and they did not put the screw through the nerve. They put the screw through the nerve, it's a whole different game. But assuming it was just inflammation, then you run from the low back, because he's motor weak and painful, L3 to S1, the whole lumbar plexus. So they probably put the screw through the synovial capsule at the SI joint. Anyway, and I said, so you just do inflammation in the nerve and from the low back, L3 down to his foot. And that's going to take 60 minutes. And then because he has motor weakness, you have to do 81 and 396, increase secretions in the nerve at the same time for 60 minutes. How many treatments? It's sensory is usually easy. So I book him for 3 1-hour things. And motor is harder. So motor is going to take however long motor takes.
Mhm.
And the practitioner I was talking to said, okay, so should I do 3 days in a row or probably 2 days, 1 day apart? So you see how much lasts, and then book the third day and maybe a fourth day for 3 or 4 days later. So like a Wednesday, Friday, Monday, Wednesday thing. So, okay. So it wasn't anything that isn't in the core, but he needed to hear it to be comfortable with it. And I said, so call this patient and get him done because this is just nerve pain. It's nothing.
Right.
And it's like, where in the world does anybody ever hear that? Where else does anybody say that?
And it could be more complicated down the road, but like you said, you have to always have a starting point. And the starting point never has to be that complicated, especially when you think of the primary complaint. And when it's nerve pain, it's the nerve. And yeah, maybe you need to run allergy and you may need to run all these other.
Oh, I forgot to tell him about metallic toxin.
Yeah.
If you're listening, try 16 for metallic toxin.
But I doubt that is so necessary. It's the inflammation and increasing the secretions that is going to get the most bang for your buck right out of the gate, right? That is the safest, most educated hypothesis that you can make. And then you have to have that ability of, this is what I'm going to start with, and this is what I expect to happen. However, if it doesn't last, if it doesn't hold, if it doesn't give us the effect that we want, these are the avenues in which I can go.
And then for the practitioner, the other thing I added is these muscles haven't contracted in 2 years.
Yeah.
So even when you get bulk back up into them, they're going to be weak. And you're going to have to reconnect his brain to his foot. And then you're going to have to give him quad sets and resisted foot exercises. So the muscle still has to be strengthened. It contract, but it's going to be weak. And when you've done this, I don't know, 400 times, I take the progression for granted because I've done it and failed and done it and succeeded and done it and seen the progression so many times that it's, yeah, this could happen and then you do this. And I guess the thing you have to get used to is being comfortable with making it up as you go along.
Yeah, I don't even know if it's making it up. It's just being able to change lanes with your different hypotheses.
Yeah.
And we always talk about being adaptable and being able to pivot and being able to change on the fly is what we use in the sports world.
Yeah.
And observe, absolutely. Like you don't, and you say it, don't get attached to the hypothesis, don't get attached to the outcome, don't get attached to any of it. It's all very fluid.
Yeah.
And when you have somebody that has been, I was thinking about this recently working with a post-operative shoulder. So this person had shoulder pain for years and years, tried everything from PT to biologics, injectables, invasive, non-invasive, tried it, had pain, finally had surgery, success, no pain, partial thickness tear, almost full thickness tear, labral tear, all nicely done, no pain, but the movement and the contraction and the confidence is a thing. And I don't understand why I don't want to move it. I don't understand why these muscles hurt so much. And I said,
why they fire in the wrong order.
absolutely. And I said, and he's like, why do you look so excited? Everybody else wants to run. I said, no, this is my space. This is what makes sense to me. This is my contribution to the FSM world, is to coordinate this. And I said, but first of all, it's the narrative that you're saying to yourself that has to change. So after 30, 40 minutes of coordinating it, and this doesn't hurt. I'm like, this feels great. I said, keep saying that. And the narrative changes faster. The contraction is stronger. It all comes together when the patient is excited and surprised. And going back to how you started with the conscious, unconscious confidence, that's exactly what we see with patients.
Yeah.
And to me, that is, you do have to pay me, but you don't have to pay me for that, because
So much fun.
it is. And that's what creates that permanent change of, I can do this.
And the other thing that is wonderful about having FSM as a tool is, I learned this with personal experience. After my shoulder fracture, we had all the muscles. Passively, I had full rein. Actively, things weren't firing in the right order. So we were out in the gym, and Jody says, no, they're not firing in the right order. And I went, put the wrapper on my neck, let's put a thing in my hand and just do 81 and 84, because increased secretions of the cerebellum. The cerebellum has a macro. The cerebellum has a script for what muscle has to fire in what order. And I wasn't afraid to move it because we'd been working on it for 14 months. And in 10 seconds, 15 seconds, lower trap. Everything fired in the right order. And we did eccentric first and then concentric. But then they turned off the cerebellum, and I didn't know how to start it.
Right.
I said, then it came out of my mouth, oh, that's the sensory motor cortex. The sensory motor cortex is the one that says, move your arm. And then it sends a signal down to the cerebellum and says, move your arm in this order. So we did increased secretions of the sensory motor cortex, and everything moved in the right. And then we did the cerebellum, and then we did the nerve. And having FSM as a tool makes that whole rehab process so much easier.
Yes.
It just makes it fun. So when you're trying to get somebody to relearn how to use the muscle in their leg because they've had foot drop or an SI tear or whatever, and it's just, the cerebellum remembers. It has a macro. So turn the cerebellum on. Once you get the nerve working and the muscle working, you'll turn the cerebellum on and see what happens. And all of a sudden, the patient says, oh, I can lift my hip. I can lift my foot. And you push down on my hand, put up on my hand, put up on my hand, put down. And it's, then they have to learn how to walk again. And so it's just like you said, it's more fun. Why are you in? I just came back from my 60th high school reunion.
You were so close. I'm sure you're busy, but
I was hanging out at the pool a fair amount for a couple of days. And everybody else in the room was retired. And I said, I opened a clinic when I 2022. And they, like, almost everybody looked at me like, are you crazy? And I said, what could I do that's more fun than this? What am I going to do? We water the geranium if I had geraniums. But what else could you do that's more fun?
I don't know.
I don't know.
I don't know. I think when you bring that excitement and joy to patient, that to me is the exciting part. And that's the exciting part for me now teaching it, is to give people another tool to help somebody else. How could you not enjoy that contribution to healthcare at the bare minimum? One thing I want to unpack before we go any further is what you were just talking about with restoring coordinated movement. one thing we talk about a lot in the sports course is, do you have to run 4089 first? And I said, no, it depends. Some people are not afraid to move it at all. But the longer somebody's been in chronic pain and the longer that they've had the story of, when I get to this position, it hurts here. Or when I do this movement, that's when it hurts. If they have that story in their head, I don't think there's any harm in running 40 and 89 first.
For a couple of minutes, yeah.
Yeah, it's not always necessary, but I do think we have to just be aware of the story they've been telling themselves. Like you always say, the amygdala gets paid to remember. It only makes sense that if they've had excruciating or limiting pain, they're not going to want to go past that range. Doing a passive range of motion where that patient doesn't have to actively control, where you as a practitioner are putting you through a range, it's not as simple as, oh, they can do it passively, so they should be able to do it actively. Again, theory, but it's not easy. And when disgruntled practitioners have been working with these patients that are also telling, I don't understand why you can't do this, that hurts me. Yes, when I hear that these patients are, and I'm like, it is absolutely reasonable that you don't want to move your arm in this way, but let's find a way that you can move it, and that movement feels strong and coordinated and empowering and painless.
And guess what? It has to be okay with the practitioner to not know what you know or not know what I know. And it had to be okay with me to not know what Jody knew when she was rebuilding my shoulder.
For sure.
Know what order the muscles were supposed to fire in. That wasn't part of my database.
Yeah.
So my injuries over the last 20 years have come in really handy. A learning model. I am very content now to not need to do it personally. I'll read a book or watch a video.
Right.
It's everything you know gives you a matrix to place, to put new information.
Right.
So I'll walk up behind somebody that is having trouble moving their shoulder, and I'll grab a fingerful, a pinchful of lower trap. It's like you need to pull your shoulder blade down, and of course they throw it back. No, down towards your belt and waist. The brain hasn't talked to their lower trapezius in 20, 30 years because they're always sitting like that. And it's then the upper thoracic paraspinals. They taught me about those in the process of rehabbing my neck.
Right.
And it's, oh. So lower trap, then serratus, and there's no way to move your shoulder properly if your pec minor is pulling your shoulder forward. And you watch how the patient is moving. And it's, oh, that's what I didn't do. So then you get on T1 and you run scarring in the nerve, scarring in the artery, torn and broken in the connective tissue attachment of pec minor to the coracoid. And all of a sudden the shoulder, that relaxes, shoulder goes back. Now the serratus is able to contract because the pec minor, because there's no way for the serratus to contract if your shoulder's like that. It'll be done. So you have to do that, and then that.
I will verbally walk through the people who are just listening on the podcast. So you are depressing your scapula, you are externally rotating your humerus. You have one hand on the clavicle and pec minor attachment on the coracoid, and that's that you're talking about.
Yeah. Shoulder drops back.
Scapular depression, downward rotation of the scapula.
And then those posterior muscles stabilize the scapula, and that is the only way for the humerus to move. You knew that. You knew that, because but over time, if I did it in chiropractic college, I had forgotten it.
No, it's funny. Every class that I teach, I bring up, who here knows, everybody close your eyes, raise your hand if you know what scapulohumeral rhythm is. And maybe less than a third of the class. And 100% of the class should know what this is. And that is, to your point, for Every 3 degrees at the humerus abducts, the scapula has to upwardly rotate. These two work in tandem with the shoulder girdle. If the scapula is stuck, the humerus is not going to move effectively. But our model of treating, whether it's insurance-based or assessment-based, is so myopic sometimes. It's just, oh, you have pain in the glenohumeral joint, and you have patients that literally just pull up their sleeves and be like, my shoulder hurts here. And I'm like, I need you to take off your shirt. Excuse me, why? I need to see your shoulder blade. I need to see your armpit. I need to see your chest muscles. They're like, why?
I have supraspinatus, tendonitis, and bursitis. Yeah, no, you don't. Yes, you do, but that's not the problem.
Yeah, exactly. And it's smiling and nodding and being like, I'm not disagreeing with you, but let's figure out why you have those ailments in the first place. What happened to the shoulder?
And that's the point at which you put your fingers in their armpit and they go, yeah, that's where the problem started. So let's do that. And then you put your fingers on the pec minor and then you do that. And then you can treat the supraspinatus, tendonitis, and bursitis. Then you have to retrain everything.
And anytime patients who are listening, you hear the word bursitis, that's not where you stop looking. And those of you who are listening, there's the most elaborate, exquisite eye roll coming to the left of my screen here when I said the word bursitis. Bursitis just means the bursa is inflamed. And the bursa gets inflamed because there's higher areas of friction going on. The real Columbo, the real sleuth of the equation would be like, I get it, the bursa is inflamed, but let's figure out what mechanically is happening to create this irritation in the bursa.
It's like, why is the bursa inflamed?
So getting it shot full of stuff isn't really the solution. It may be analgesic for a little while, but you're not fixing anything with that. As far as
if you reduce the inflammation in the bursa, then the notification to the brain that this movement is injuring something, you just turn off. It's like putting a tape over the engine light.
Yeah.
The check engine light comes on and you're, instead of checking the engine, you just put a piece of tape over it so you can't see it. That's what injecting that, not injections are bad, but
injections can be great. The right injection can be phenomenal, but it's looking at, and that's one thing I was thinking about the other day at work was FSM. And a patient had made a comment. I know it stands for frequency specific, but you're very specific. And I said, thanks. But you also have a very big picture approach. And I'm like, thanks. And it's both right. You have the ability to get so specific with pathology and tissue type. But if you don't have the big picture approach, it doesn't work.
And I think it's because we have frequencies that allow and require us to do both. What is that? Work locally and think globally. So work locally on the shoulder and think globally. So patient came in with nausea and that medulla, and there's this nausea center in the brain, but it's the vagus. And so she came in with nausea and they thought it had to do with the auto accident she was in. She got a traction injury, mom thought, in her vagus nerve. And then the kid, she was 16, the kid said, Mom, I was nauseous before that. And I said, when did the nausea start? September. I said, what happened in August? Nothing. I had COVID in July. So basically she had long COVID in the vagus nerve. Now, the auto accident didn't help, but what reduced her nausea and made her feel better was the virus frequencies in the vagus and probably the stomach. She's coming back on Friday. The stomach and the small bowel. It's like, why? Nausea is complicated. We call it the barf center in the brainstem. and nucleus something or other. And Y is local. They've already ruled out everything. Doesn't have H. pylori, doesn't have this, doesn't have that. So we know 6 bad things it doesn't have. That leaves us with 2 things that we can fix. Vegas is pretty easy, and so was long COVID. And she felt better. But work locally, work on the vagus, think globally, what happened just before?
The nerve traction is probably relevant, absolutely. But yeah, when the patient has this happened before that, I'm sure, like you said, the auto accident didn't help.
Made it worse.
Right? So if the vagus is already impacted by COVID and then you have a nerve traction injury, that's not helping turn anything on or function any better, right? That added insult to injury, added trauma to it.
Yeah. Life for FSM practitioners would be a lot easier if it was only good for one thing, really. The fact that there are so many possibilities of what it can do and how it can contribute to recovery gives you an opportunity for ongoing cocoon to butterfly.
Right? No, again, it can be, and there are times, I'm sure, like anybody, you can get just so overwhelmed at the infinite possibilities that could be arising, but treat what you know and treat what works. Like nerve stuff is the easiest stuff out there, which whenever I hear myself say that out loud, I do have to stop because that it shouldn't be happening that easy.
And it's way for lightning every time I say that, but it's true. But there are a lot of things that are easy for us to treat, but nerve pain is honestly the easiest thing we treat. Wound healing, yeah, that's easy. But nerve pain, there is no place on the planet where anybody else can say nerve pain's the easiest thing we treat. So Kevin found somebody that wants a research proposal. So we want to apply for a grant. And I said, we had a grant to study anything. It would be, how is it that only 40 and 396 and 81 and 396 treat pain and motor weakness? How we have no data except for clinical observation that you can take neuropathic atrophy and reverse in 60 minutes. So you take it from 32 centimeters to 34 centimeters in 60 minutes. You can do that. Yes, I should have published that case, but without data as to, but what's going on? Will it hold? How many times do you have to treat it? What exactly are we doing to, and 396? Does 380 work? No, not really. Does 400 work? No, not really. It's 396. And 81 is the thing that makes the muscle go from 32 to 34.
Right.
If there was a grant to be applied for, that's the one I would apply for. When I retire, in air quote, I am going to start on a PhD in neuroscience. Because if we haven't done a study already, and I'm pointing at Kevin, if we haven't done a study already, I want a squid axon. And I want to find out what on earth we're doing when we run quiet inflammation in the nerve, and that stops neuropathic pain. After you've done it 50,000 times, okay, that's easy. And then increase secretions in the nerve, and you make foot drop go away. Unless, of course, the foot drop has been caused by polio. If foot drop has been caused by polio, then you have to run the frequency for polio, which I think is 23.
Maybe.
Yeah, 23 in the nerve, at which point, after 30 to 60 minutes, the foot drop goes away and it's permanent after 60 minutes. After 50 years, the guy was 57, he got polio when he was 5, He got out of the hospital when he was 7. And polio in the nerve got rid of his foot drop. And 10 years later, he came to an exhibit that we were having at the meeting, and he can't miss him. He was 6'4" with a cowboy hat on. And he told everybody that was standing around the booth, yeah, I had foot drop and she treated me for an hour. And see, I can still stand on my toe and stand on my heel. And we're on the planet. I don't know. Makes it fun being us.
And now, like, yeah. So because I'm writing this, I'm compiling this case study right now. But now I'm like, okay, so part 2 to this paper is going to be, why does 40-396 work and 81 and 396 work?
We have no idea. It's like, we have no idea. And there is what's the word? You just have to be tolerant of the fact that it is clinically reproducible. And that's all we know. There's no way to know how somebody in 1920 decided that 396 hertz was going to resonate with the nerve and 81 hertz was going to increase accretions in the nerve. There's just no way to know that. And that then you have to trust your clinical observation and the fact that it's reproducible.
Yeah.
And then one day, in this life or the next, we will know.
Yeah. And it's funny, like you go through waves of it, right? Like that learning curve of, I think when I was new, I was so caught up in, but why is 40 inflammation? Why is 390? Why? And then I don't know where that part goes, where you just care less about that. Why? Because, and maybe the confidence and the results start creeping in and you're just like, I'm not questioning it because it's just, the belief is there because I'm seeing result clinically. So
after you've done it 50 times or 100 times, you don't care why, you just know that it works. Like when I push the start button or put a key in the ignition, the complexity of an automobile engine, especially these days, how it works is overwhelming. When I was, 17, I asked my dad, plug do. An hour and a half later, there's diagrams and drawings of gasoline and carburetors and ignition and pistons and the drivetrain and all that stuff. And it's, whoa, dude, all I really need to know is I put the key in, I turn it, the car starts, I go to the store. That's fine.
yeah.
That's what it's like with, why does 40 and 10 work on it? Why does 40 and 396 take away nerve pain? I don't know. It does.
Yeah.
But just start the car and go to the store. Run the free.
And again, it's that complexity, that myopic big picture, it's everywhere, right? Just a really quick story before we go to some questions. I was talking to a psychologist friend of mine, and they were talking about like dealing with trauma, right? And the analogy she gave me was, some people are just numb. And then in part of their therapy, they go from numb to being very hyper aware and hyper vigilant, and all the emotions are extreme. And then it normalizes. And I said, oh, that's just like when we treat a nerve with FSM, actually. She's, excuse me? I'm like, it's just like a peripheral nerve. Yes, it goes from numbness to hyperesthetic, and then it normalizes. She's at about. And we're both eating our salads. So I thought the two parallels were quite funny.
Oh, well.
Okay, so a couple questions on here, and then I've got a couple that were emailed. But Dana had asked, what does running metallic toxin do?
I don't know.
Sometimes he was like talking to one of my teenagers. I don't know.
Metallic toxin, Jody probably had the best case. The frequency for metallic toxin on the advanced list is 16. Right. And I don't know what it does. It's 16, not 19, and it's not 18. It's 16. Okay. And she had a patient with pain, like referred pain from the gallbladder after the patient's gallbladder was removed. And they did scarring. And
It was me. I had phantom gallbladder person.
oh, okay. You and Jody had one first, but you had one too. And it turns out that the staple they used to seal up the area was stainless. And the patient's allergic to chromium. And the only thing that worked was allergy reaction and metallic toxin. The pain went away. And in, I don't know, Jody's patient, it was permanent.
Yeah. My patient bought a custom care because hers wasn't permanent. We figured it got her 13, 14 days. And then she would have to come back. And the staples aren't going anywhere. So I might as well just buy a machine. And it's been at least 11, 12 years. And patient's doing fine. No, do you remember? That's when I called you and I was like, is there such thing as phantom gallbladder pain? You're like, what? And I'm like, this is what I think is happening. So yeah.
And you'll run into the same thing when I put in a stainless steel knee or a stainless steel hip. You're not going to, the only thing worse than a knee or a hip replacement is a revision. So nobody is going to remove it. Fortunately, apparently the word is getting out in the orthopedic community, and everything that's going in is titanium because the allergy response, I think, is less than 3%. It's really tiny. Yeah, I wish I knew. And that's one of those things that I don't even know how you would study that, at least if you're studying pain. You can take a squid axon and study it, but how do you study what 16 does? And Leaf, sorry, I want to go back to Leaf's question. He missed last week. He was at Indralaya for Therapeutic Touch. Therapeutic Touch was started by Harry Van Gelder's sister.
Wow.
And that was pretty fun. But he came home with COVID. So Leaf, the COVID frequencies. And if you don't run, you need to look at we call it flu respiratory webinar. And there's 38, 41, 44, 56, 160, 189 are the virus frequencies. And then you just pick the tissues that are giving you trouble. So that'll be fun. Guarded response. Dana, I have a guarded response to new ideas or suggestions. True. Is there afraid to move an equivalent for emotions? Oh,
we do have fixed ideas for the emotional response.
970 and 23. But I think guarded response, if I had to translate that, Dana, I would call that afraid to make a mistake. Because when you're doing what you're used to doing, it might not work, but at least you know what to expect.
Mm-hmm.
When you try something new, it's different than what you're used to. You don't know what to expect. And of course, you're guarded. I'm guarded every time I do something I haven't done.
Mm-hmm.
And try concussion in Vegas. And 970 and 27, just general fear. And 970 and 23, fixed ideas. And there's also the possibility, thinking as a psychologist, about the hippocampus. Gets paid to remember every bad thing that ever happened to you, even if you don't remember it. What if sometime when you were 5, you decided to try something new and you got hurt or something bad happened? You don't remember what happened when you were 5, but your hippocampus does.
Mm.
Or maybe 5 minutes on 40 and 89, which is concussion in Vegas has 40 and 89 in it.
Mm-hmm.
That guarded response, Dana, that's eloquent language. Guarded. I'm afraid to try something new, but I don't know why. If you're afraid of it and you don't know why, it's the hippocampus in my world.
Yeah.
And I put my money on that. And then, Gabby, have you ever treated black lung? No. But I have an N of 1 from Steve Spicer, who's one of our practitioners in Southern California. Her dad had been a smoker for 40 plus years, maybe 50 years. And I think he was diagnosed with COPD. And so she treated him with toxicity and nicotine and something else. Just go down the advanced list, carbon, whatever. Treated all this stuff in the lung and the bronchi. Treated her dad like 3 times or so. And because he had COPD, they went in and scoped him. And his lungs should have been black, and they were pink.
Wow.
So it's an N of 1. It wasn't black lung, but it was a 40-year smoker, which is similar. And you can't hurt him. A black lung patient is doomed anyway. So it's not like you can hurt them. Torn, broken in the lung, toxicity. I can't remember if there's something for charcoal or carbon. Minerals, hardening. If you think about what silica is, so 217, look down the advanced list, and as Kim said last week, just wait for something to show up in bold print and would be worth it. Oh, coal has mercury in it too. Oh, ick. Okay. Yeah. Good luck. I told you about the lady with anxiety, where her anxiety started when she was 9. And now she's like, when she came in to see me, she was in her 40s. I've been anxious since I was 9, just anxious. And her grandmother was bipolar. And what happened when you were 9? I had 12 mercury fillings put in all in one day. I ran mercury in the midbrain. The anxiety went away. Mercury 55 and 00, which is the constitutional type. And then 55 in the midbrain, she got completely stoned. And she said, the anxiety's gone? No. And 2 days later, the next day, I ran it again, and she got stoned again. And so the custom care she brought, I put mercury anxiety. And I said, just run it when you feel this particular way.
That's fascinating, because I was listening to a podcast a little while ago of a psychologist saying that all anxiety, his opinion is all anxiety is childhood trauma based.
No.
It would be really nice if it were that simple, but
yeah,
sure.
Sensitized.
But that's interesting to trace back what happened when you were 9. That person thought about the feelings, because not everybody would put that together. They might think, oh, I changed schools, or my parents got divorced, or I was bullied, or something.
And if you listen very carefully, the patient will tell you what's wrong with them. And it's...
Debbie had asked who my mindfulness course was with Twist University. So he has a really great...
Peter Twist?
Peter Twist, yes. So a bunch of online courses. Peter Twist or twistuniversity.com or .ca. You could, it's fantastic. I finished it, but I miss it. But it gave me so much insight. And I think those of us who are working with patients, not all of us have a psychology background, like you, my friend. I think we get really caught up in a lot of like the biomechanics of continuing education. We want to learn about fascia, and we want to learn about assessment, and all that is very relevant. But those of us who are working with complex cases, a lot of it has to do with your patient interaction and how to be their cheerleader when they need you to be their cheerleader. But for me, it's sitting and listening and not telling them that they're crazy or their symptoms don't make sense or there's nothing that you can do, because they have heard that on repeat for so many years.
Are you the one that said that the patient told you just to have you sit there and listen to me? Oh, no, it was Sandra.
No, yeah, I had a patient that drove over 2 hours and said just the fact that you sat there and listened to my story has been worth the drive. It was worth it there. And to me, I was just like, because sometimes I don't even want to charge for the assessment or the intake because it takes so long and I feel like I'm not doing anything but making eye contact and listening and taking notes. And I draw diagrams where I should start and where the bubbles are potentially overlapping. And
I open up Netter and show them what their ear looks like. And
speaking of Netter, somebody wrote to me, what is Netter and why do you guys keep talking about it? From the clinic. This was my Bible. This was Netter's second edition.
wow.
I don't know what they're on right now because Frank Netter died in 19. So he's obviously had other people come in and do their drawings. But Frank Netter was a medical doctor and an artist who
was a surgeon.
And he drew in his free time until he started compiling all these illustrations. And when I was in college, we had a anatomy coloring book, so we didn't have to draw it, but it was almost like those mandalas that you can color that are very like meditative. That's what I felt I would color in my anatomy coloring book, and you're coloring along the lines of the striations of the muscles. And so to me, and I don't think of myself as a creative person at all, I really felt that it helped me learn because I felt like I had both hemispheres in my brain together.
And you have, when you color it, you have the kinesthetic, you have the visual. It's a way to put it all together. I don't know if you can see back in that corner, that stack of green books on top of that file cabinet there in the corner. Those are Ciba, what is now Ciba Geiby, but that's Ciba was CIBA, was a pharmaceutical company, and the Netter Atlas of Anatomy started out as the Ciba individual books with Netter's drawing plus verbal descriptions of the digestive system, the nervous system. Each of the systems is in a separate book. So that's the whole collection from George's house. And between him and me, we had all of them. And that's when the copyright on that ran out. Netter was able to put them, because those were in the 70s and 80s. When that ran out, Netter was able to put them in his own atlas and publish that with just the drawings without all the blah, 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 blah. And there are sometimes I wish there was a way to open up a picture or stand behind it and look at it from the other way. And it isn't perfect, but it's awfully cool.
It reminds me of those videos of like cats or dogs looking behind the TV or behind the computer to see like, where did the dog go? Because I've had those moments when you're looking at something in 2D and you're just like, oh, what is that curve? Louise had asked, I think, where we can access previous recordings. So anywhere you listen to podcasts, Spotify, iTunes, and if you want to watch, because we're so much fun to watch, go to YouTube, and you can see all the little animated movements that we make.
The eye rolling.
The eye rolling. It's funny. I had a patient who watched everything on YouTube and was like, every time I would go to do the dishes and then Carol would say, that's a good face, I had to run back really quickly to do what your face did. And then why did she make that face for? Well, what was it? Sometimes I don't understand. And sometimes it's just, I don't know.
When we were at this reunion, there's the woman that actually organized the reunion is a patient of one of our practitioners in Northern California. So she read The Resonance Effect, and then she watches it on YouTube. So she's telling people at the reunion, you got to get this book and you got to see her on YouTube. And it's, oh my God. And it's, we're everywhere.
Who would have thought our little COVID Wednesday boredom morning meetings were going to turn into something that would stick like this?
Who knew?
I'm grateful that we do it because I think it's a nice platform for everybody to get some more information, what we do, and it's not so scary.
Yeah. Oh, speaking of what we do, Michael Stone, promised everybody that he was going to be at the advance this year. He said he wasn't going to blow me off, and he was going to do physical exam for functional medicine. It turns out that he's also Uncle Mike, and he has to be in Spain for a wedding that weekend. And he said yes before he checked with his wife, who has the calendar in her head. And so we are probably going to schedule him in Troutdale for a weekday, like a Saturday, one-time seminar, and get it on videotape. And we'll have him in 2026.
That's great.
Yeah. And we had, where are we for time?
4 minutes.
Okay. Yeah. We had a patient who ran 40 and 89 on herself for 6 hours.
You talked about this last week. Yep.
Yep. And Patrick Wood, who is a friend from, I don't know, 2000. We were both on the fibromyalgia circuit for about 5 years, from 2000 to about 2005 or 6. And Patrick's specialty was dopamine and the midbrain and neurotransmitters and all of that. And I did not understand how running 40 and 89 could cause the symptoms that this patient had. And so I emailed Ben Catholi, Dave Burke, and Patrick Wood. Okay, Brain Trust, what did I just do? What happened? And Ben had an idea, and Dave was like, I don't know. And Patrick says, oh, it's this. And he said it, and I read it, and it's beyond me. But he absolutely explained how 81 and 89 would reverse it, why it did that, when to use it, and what supplement to use to get it to last and support it. And so I already asked Dr. Wood to lecture next year at the Advanced, and I said, Patrick, you just found your topic for next year, because if it makes my brain hurt, you all need to hear it.
Absolutely.
It's going to be really fun. More than you ever wanted to know about the thalamus and the hippocampus. It's
That's
like,
exciting.
it really is, in a geeky sort of FSM. Wow.
Has it any other way to be when you go to the advanced, though?
I don't think so. It's much fun.
It is so much fun to be in an environment where you can geek out just as hard as the next person, and you're not shamed or blamed for it. It's exciting, and
Yeah. And I just sent an invitation to Juliana Mortensen, and Jay Shaw is going to speak on Sunday morning.
oh, great.
And he said, you just need to get me out of there in time to catch a 1:30 flight back to Washington. It's who else on the planet knows the flight schedule between Washington, D.C. and Phoenix in his head at 9:00 at night when he's emailing me. So Jay Shaw is going to talk about what we've been doing with, you treat the muscle tightness and muscle trigger points by treating what's causing them. We
Yeah.
make neck muscles turn to pudding by treating the facets and the discs and the ligaments and torn and broken, and the muscles turn to pudding. And so he's going to put all that together. So we got Jay Shaw on Sunday.
You've been saying it forever because it's never the muscle. And I remember the moment I heard that for the first time, it was like a dagger going right through my heart. And then at the same time, this feeling of hopelessness because I only treat muscles. So if it's never the muscle, I guess I'll just curl up and die. And then it was like, oh, no, the muscles are reacting to something. Wait a minute, this makes sense.
Yeah.
Biomechanic in me was like, of course, that makes sense. Why is this happening? And so to have somebody like Jay Shaw really break it down is going to be super exciting.
I'm
The podcasts are getting faster and faster. I always say it's like the vortex, because if only I could run for an hour and it would be like this quick, that would be
easier.
Maybe I should listen to the podcast while I run. That could be something.
It really is. It's like some sort of time warp thing. We started 3:00 and 5 minutes later it's 4:00.
The wormhole.
Wormhole. That's it.
All right.
What a way to get to Andromeda.
I'm not sure if this helped anybody, but I had fun. Thanks everybody who's here live watching. We'll be here next week.
No, actually, you're going to be on your own next week and the week after, because we are going to be in Ireland next week. And the week after that, I'm going to be in Austria.
That's right. I will be here.
So you will be holding down the fort in case the fort decides to try and go someplace.
All right, everybody. We'll see you guys next week.
See you next week.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.